All right, perfect. Well, thank you for the planning committee for inviting me. It's my pleasure to present in this conference. So my talk will be touching on the use of cardiac magnetic resonance in the TAVR planning and two components, the use of non-contrast for TAVR annular sizing and then predictive value of some MRI derived parameters. This is my disclosure, and the outlines will be basically an introduction about the prevalence and prognosis of aortic stenosis, and then routine imaging right now as part of the planning, then non-contrast MRI use, and then the emerging role and predictive value of cardiac MRI parametric imaging in severe AS. And then I'll present a couple of cases that were performed by Dr. Tandon as well. So again, as Dr. Tender elegantly alluded about this, aortic stenosis is basically very common and associated with poor outcome. And it is considered one of the most common valve diseases and expected to increase in prevalence due to the aging population. So the interesting and most alarming thing is once it becomes symptomatic, the natural history here showed emphasizes there is dismal outcome once it becomes symptomatic, and there is here long pre-symptomatic period and where the patient becomes asymptomatic and they're asymptomatic but they have severe AS, and then dismal outcome. So it's very important to catch the disease at this point and implement therapeutic options. And TAVR has become an acceptable non-inferior option to surgery in low, intermediate, and high-risk patients. Imaging before TAVR is an essential component of the procedure's safety and success. And multiple things needs to be looked into before implementing the TAVR valve, including the annulus, the aortic valve annulus here, which is a systolic measurement at the peak systole, and then the coronary height, the left and right coronary height, to make sure the valve would not obstruct the ostia of the coronaries. Also the sinutubular junction, measurement of the entire thoracic abdominal aorta, and the femoral arteries to make sure that the transcatheter valve mounted on the catheter can be passed safely to the aortic valve. Currently, cardiac computed tomography or cardiac CTA is the reference standard for valve sizing, and it has been used in all the trial that validated the current use of the prosthetic valves in TAVR. So why cardiac CTA is the gold standard? Basically, a high spatial resolution of that modality and the fast scan time, broad availability gives it advantage over cardiac MRI. And this is basically seeing images of cardiac CTA showing the valve movement in systole diastole severe calcification. It's a pretty high resolution imaging modality. So, however, using this modality could be very challenging in patients with high risk for contrast-induced nephropathy or severe allergic reaction to contrast. Again, cardiac CTA has advantages in short scan time, very well established and available, and reading it is it requires a specific kind of competency, and then disadvantages of ionizing radiation and risk of contrast-induced nephropathy. On the other hand, if you consider another cross-sectional imaging, there's a cardiac MRI, which has multiple advantages over CTA and also some disadvantages. The main advantages are no ionizing radiation and no iodine contrast if the patient has severe contrast reaction to iodine. It can be also performed free breathing and arrhythmia generally tolerated. However, also it comes with disadvantages like long scanning time, claustrophobia, because you need at least 39 minutes in the scan, and then not readily available, and you will be using another contrast agent here called gadolinium, and there is a risk of having nephrogenic systemic fibrosis or sclerosis. An important concept in cardiac imaging I want to touch on just to differentiate like what imaging modality is the best for the specific organ that you're imaging is basically the spatial and temporal resolution. Spatial resolution is the measure of the smallest object that can be resolved by a sensor. So if you're really measuring a very tiny, small object, you need to choose a modality that has that spatial resolution capability, like CT. CT has a 0.5 millimeter spatial resolution, so it can measure structures as small as 0.5 millimeter compared to MRI. It cannot measure less than 1 millimeter structure. Another component is the temporal resolution, which is the ability to resolve fast-moving object and is comparable to the shutter speed of a camera. So are you imaging like a rapidly moving structure versus a slowly moving structure? And hence here you determine which modality. So overall, MRI and CT, basically CT is superior in spatial resolution, but all inferior in temporal resolution. So there is a trade-off in both. Ultimately, CT would be the first line choice, but if you cannot do CT for those patients, what options you have? Main question here, can cardiac MR angiography be used for accurate measurement of the aortic valve annulus prior to TAVR planning? There are multiple challenges in cardiac MR imaging, preventing this modality from being very popular and constitute challenges here. To have a high resolution MR imaging, you need to give MRI contrast, which is the gadolinium-based contrast. And also, if patients with chronic kidney disease are getting gadolinium contrast, there is a risk for having nephrogenic systemic fibrosis. The standard acquisition in cardiac MRI is in the diastolic phase, which is done like this to minimize motion artifact from the heart in peak systole. So all the nice looking high resolution images in MRI mainly done in diastole, which is not helpful when you're trying to image a structure in peak systole, and like TAVR planning. And the systolic acquisition of MRI, if you change the sequence and make it systolic, you're subjective for motion artifact. Also, calcification, which is very common in severe aortic stenosis, generates signal void on MRI, which makes it very challenging to accurately outline calcified structures. Again, the FDA black box here about using gadolinium contrast and the risk of nephrogenic systemic fibrosis. And so here it becomes a challenge when you have a patient at increased risk for contrast-induced nephropathy and cannot get gadolinium contrast, and you want to image their aortic valve in systole using an alternate modality to cardiac CPA. So we try to do non-contrast MR angiography, which is very well validated in diastole, and we use it for patients who had a contraindication for contrast. And again, it is done in diastole. And this is basically a comparison of the dynamic traditional contrast 3D MR angiography, which is a very high resolution, and you can get all the structures you want. But again, it's done in diastole. This is a similar diastolic acquisition non-contrast MR angiography, and you can barely differentiate the same because this used like a technique called SSFT in MRI, which uses the patient's blood as a contrast. This is a no IV injection, no contrast, nothing, uses just the blood. It's pretty high resolution as well, with a temporal resolution up to 1.25 millimeter. You cannot get it better than this, still inferior to CT, but 1.25 millimeter can still do the job in valve planning. Then looking into studies that validated the use of this non-contrast MRA, basically very limited studies in single centers, and not all of them used the actual systolic acquisition of MRI. Some of them used diastolic acquisition and did like a corrective factor model based on CT comparison, and basically the accuracy is not as you would like it to be. This study here was done as a 69 patient with severe AS, actually underwent both CTA and MRA, and they compared the annulus measurement in MRI and CT, and based on the systolic difference between systolic diastolic measurement in CT, they applied this corrective factor to the diastolic acquisition MRI and came up with this 7% factor. And just basically, you cannot generalize it to all population, and it's a single center studies. Another study here with the limitation that they did model the systolic measurement of the annulus compared to the diastolic one, and they use the 6.5% differences. So basically, they use the traditional diastolic 3D MR angiography without contrast, and they measured the annulus and they added 7.5% corrective factor, and they proposed that would represent the systolic acquisition, the systolic measurement of the annulus. And there has been discordances among the readers, and majority of them were when there have been massive calcification. So again, I don't know how reliable these measurements were and how confident the interventions would be proceeding with valve in these implantation. Finally, there was a study that did the actual systolic acquisition and validate of the aortic valve and validated against the cardiac CTA with decent results here. It was single center, small sample size, 21 patient in University of Pennsylvania, and all patients underwent pre-TAVR, CT, and MRI, but the MRI was tweaked to be acquired in systole, subjecting the images to motion artifact, and it's very challenging. They did it on a 1.5 Tesla Siemens, and their conclusion was the 3D MR angiography could provide an alternative method for annular sizing pre-TAVR compared to CTA. Well, we took their measurement, we applied it to our patient population for select patient referred to our TAVR clinic with chronic kidney disease. And unfortunately, especially when we use it on a 3D Tesla scanner, the image resolution was pretty low, and we could not confidently measure this. When I show it to Dr. Tandar, he took it with a grain of salt. So we collaborated with our Utah Center of Advanced Cardiac Imaging Research and looked into our own institutional protocol, modified a standard Siemens protocol, uses the 3D SSFP sequences, which it uses the patient's blood basically as a contrast. And we set up a systolic acquisition using those sagittal orientation and tested it on 1.5 Tesla, 3 Tesla scanner, compared it with CTA as well. And we basically were able to image the aorta and aortic valve in systole with minimal motion artifact. This is basically a normal volunteer. He's one of our motivated cardiology fellows volunteered for this. And as you can see here, the aortic valve is imaged in peak systole with all leaflets, very well visualized. And this is the same sequence in the University of Utah sequence applied to a patient with severe aortic stenosis. And this is how the images look like. Basically, you can see aortic valve leaflets basically signal void, severely calcified. And this specific patient happened to have a cardiac CT because there was concern about aortic dissection, and the referring doc ordered cardiac CT just, for more confidence in the diagnosis here. And this is the comparison head-to-head, basically the valve leaflet in systole compared to the MRI on the same patient. As you can see here, the calcium appears bright in CT and it's signal void in MRI. So we developed our institutional protocol, which basically uses localizers, cine images of the aortic valve, and looks into the peak systolic acquisition and set up the trigger for the MRI. And we believe this simplified method is built on the Siemens stock sequence that can be reproduced in any Siemens scanner in any place, which does not require any specific post-processing. And the 3D MRI comes in 3 different sets, one for the aortic valve annulus and one for the thoracic, one for the abdominal. And each one of those takes about 10 minutes. So overall total scan time is 30 to 45 minutes and no IV access needed, no contrast injection. We use this mainly for patients at high risk of contrast-induced nephropathy and do not need to be, mainly CKD and gadolinium use in those also is at increased risk of having long-term complication. This is just an example of our, our institutional images of the thoracic aorta, very high resolution, 1.25 millimeter, and we can measure the entire thoracic aorta, here the abdominal aorta, and we use it with high level of confidence and provide measurements here to the operator. Now I'll switch gear, and this is a brief follow-up for what Dr. Tandor mentioned in his talk about the use of cardiac MRI to predict who would do well versus would do worse post-TAVR intervention based on specific MRI-derived biomarkers. There has been limited studies using this concept of myocardial fibrosis, which is being detected by MRI parametric imaging. It is, I will just briefly touch on what those parametric imaging means. Basically, there are two components you can detect on cardiac MRI in terms of myocardial fibrosis. The diffuse myocardial fibrosis, which is a reversible form of fibrosis and called early fibrosis, that you can basically detect it by measuring parameter called extracellular volume of the myocardium and another one called the T1 mapping of the myocardium. In brief, both components uses the characteristics of the myocytes protons, and based on the damage or no damage for those protons, the speed, the velocity of the movement of those protons will change if there is any pathological process going on, and basically indicates fibrosis or inflammation. And that is considered reversible because you can have elevated ECV and T1 mapping values. If you have an ongoing disease, if you treat it, then you repeat the cardiac MRI, you can reverse that, and hence reversible fibrosis. There is another form of fibrosis called the replacement fibrosis, which is basically irreversible scar and detected by late gadolinium enhancement, and the majority of the audience probably familiar with this. This is basically a permanent scar developed in the myocardium that you cannot change regardless if you treat the process or not. And this is a result of the initial ongoing reversible fibrosis that was, going on for a prolonged time and then became irreversible. So the concept here, if we know from several studies that severe aortic stenosis is a progressive disease and causes myocardial fibrosis. And there have been studies showing that there is initial stages of reversible myocardial fibrosis, which is basically here in green. And if you intervene, mainly studies show in TAVR, surgical aortic valve replacement, they showed that this reversible fibrosis becomes really reversible and you can reverse it. But if you intervene after you get scar, which is here in this purple blue, you will not be able to reverse it. So the common sense here, if you have a disease like severe aortic stenosis causing myocardial fibrosis that could progress to become a scar, if you intervene at the point where the fibrosis is reversible, you may improve outcome. And this has been studied in a multi-center study involved for 400 patients with severe aortic stenosis in patients across 10 centers, Europe, America, and Asia. And they looked into this parameter called extracellular myocardial volume in patients with severe aortic stenosis. So basically, they recruited all patients with diagnosis of severe aortic stenosis undergoing aortic valve replacement. 3/4 of the patients, or 80% of those patients, basically went for surgical AVR, and the minority had TAVR. And they looked into this myocardial markers of ECV post-intervention. It ended up basically the TAVR is 67 patients and 300 patients with TAVR. And they looked into their outcome post-surgery, and basically here, based on the ECV, if it's tertiles, like above 30% ECV, which is considered abnormal in the standard MRI acquisition, and they do basically worse. And ECV showed as proven as a powerful independent predictor of long-term clinical outcome. And that was like basically provoked further studies, and there's an ongoing study called the Evolve trial. Basically, they're looking into asymptomatic, those patients were symptomatic here in this trial. They're looking into these parameters in patients with severe aortic stenosis and asymptomatic. And the theory is if you have the fibrosis in those patients, why not intervening versus waiting until they have scar? If we know that, the higher the fibrosis they have, the worse they do. So basically intervene when their fibrosis burden is less. And the study conclusion was in patients with severe aortic stenosis, schedule for aortic valve intervention and increased ECV has been shown to be a measure of LV decompensation, powerful independent predictor of mortality. We'll conclude by just showing two cases of our cohort. This is basically Dr. Tanda referred to this case, 85-year-old with history of CKD stage 4 severe aortic stenosis undergoing valve TAVR evaluation. You can see this is CT images with MRI, non-contrast, looking at the valve, reduced leaflet excursion, and basically turbulent flow. And this patient had two modalities, CT and non-contrast MRA, and the analyst measurement was 4.3 centimeters square versus here 4.4, and that was concordant and indicated sapien valve 26. And Dr. Tander performed this, and those are post-valve deployment echo images, beautiful, well-seated prosthetic valve and no paravalvular or valvular regurgitation. The patient did very well post-procedure. This is a 79-year-old gentleman, advanced CKD and creatinine of 8. He completely refused to have any imaging with iodine contrast and basically underwent our institutional protocol non-contrast 3D MR angiography showing his aortic valve here. We did the measurements and it was indicative of again 26 millimeter sapien valve, and he actually underwent the procedure and post deployment no paravalvular leak, well-seated valve.
Sorry, Dr. Mark, your time is up.
Okay, here's my summary. Basically, the 3D MR angiography is a feasible imaging modality for valve sizing post-TAVR, and there is an emerging role for cardiac MRI perimetric imaging in severe ES as a measure of LV decompensation predictor of outcome. And thank you very much.
Thank you. Thank you.